welcome to Clear Vision Wednesday. I'm Claudia Mühlenweg. I am the founder of the Natural Clear Vision Institute, and I'm here every single week live sharing all things about vision improvement, about how you can see clearly naturally, and covering all the different aspects that affect our vision. So subscribe right now to subscribe to this channel and click the little bell icon so you get notified. So today I have a dear colleague and friend, and this is a topic that so many of you had questions about. What all about the eye exam? Like, why should I get an eye exam? Oh, I haven't gone in 10 years. Is that a problem? And I'm going to bring my friend on, Dr. Radka Toms. Welcome.
Hello, nice to be here.
You are an ophthalmologist. So maybe before we even get into the nitty-gritty, like, can you quickly, because people hear about optometrists and opticians, and what is the difference really quickly between an ophthalmologist and, let's say, an optician or optometrist?
So we talk about it before we jump on the call, how it's in each country is really, the differences are huge. So here in the UK, when I practice, we have opticians and we have ophthalmologists or optometrists and ophthalmologists. And we ophthalmologists, we more focused on a disease prevention, disease treatment. We do cataract surgery, basically we are eye surgeons. Compared to, so we do conservative treatment and surgical treatment. Conservative means if you need drops prescribed, or if you need, for AMD, for example, injection, that's really on the ophthalmologist side. Compared to optician, they are really focusing on make sure that your vision is up to date, that your vision is the best you can, and they can try doing it with modalities like you, Claudia, naturally, or what is the majority of people do, it's prescription. So refraction is included in this. Of course, ophthalmology as well, sometimes we do refractive surgery, but that's a field of that is not classic in the the daily bread of ophthalmologists. Is more about prevention of disease and really disease treatment. So from a corneal ulcer until glaucoma. So basically from the diseases from the surface of the eye until the retina. And optic nerve, of course, neuro-ophthalmologists, which includes the brain. So it's more kind of a treatment compared to opticians when they really focusing on the vision as such. And we more focusing on the tissue of the eye. So it's all healthy. And if not, then we do steps to improving it.
So to me, great, thank you for explaining that. So refraction is really like the light is bending, for those of you that might not know that word. So it's what we usually in layman's terms say 20/20 vision. It's like glasses, contacts. You basically how you see on the eye chart, eyesight, the visual acuity aspect, versus ophthalmologists, which what you are, focus more on really checking your eye health. And then, obviously you do a lot of education in the field of nutrition and light and all these things that help you to actually prevent getting these diseases. But if somebody gets a disease, you can also diagnose this, find it, and then treat it. Okay. All right. So
and also, I just want to mention that this is in the UK. It's very specific. For example, in other countries in Europe, ophthalmologist does the whole thing. And if you go to US, it's similar. Ophthalmologist does from refraction into all the disease diagnostics and treatment. It's just here in the UK specific, so we don't do the refraction as such.
So you don't do the refraction at all. Okay.
No.
Okay. That's interesting. My second cousin is an ophthalmologist in Germany, and so they do measure you in the autorefractor, and you get the prescription for glasses, but at the same time, she would always say, no, don't get those glasses. Just, if somebody like just get some reading glasses. So, but basically a lot of opticians have a shop selling also glasses and contacts, versus you guys in the UK, you don't even really measure refraction, but some other ophthalmologists might do that, but you're not selling glasses. You're basically just giving people, this is what I measured, and this is, okay. So let's go into the different steps. So when a patient comes in for a comprehensive eye exam, what are the different machines and the different tests? And is it different when somebody's a new patient versus somebody coming back? Can you walk us through all these different things where you put your eyes in and you look into this thing and you don't really know what's happening?
For sure, yes. So it's important to really, the screening is really important. So as we talked as well before the call, that even in medical school, I learned that every year we need to get checked from dentist, ophthalmologist, and gynecologist for women at age of 40 plus. This is something that kind of stayed with me, and I think it's really important to screen. So everybody here should, of course, you've probably been to ophthalmologist, but especially if you have any family history of eye condition, such as glaucoma or age-related macular degeneration, you have to see ophthalmologist and really follow up, because the risk of this condition increase with age. And that's why it's very sad when sometimes I see a 60-year-old man that suddenly has vision disturbances, went to optician found out visual field defect, which I will talk about what it is, basically something that he could not see the top of his vision. And then he comes to us and we diagnose glaucoma. But the problem with this diagnostic is that the glaucoma is irreversible. And so we want to really make sure that we screen people largely and really make sure that we can prevent this, because you can really treat it these days and the progression doesn't need to happen. So that's the biggest mistake I see in my practice, that people don't go regularly to check the eye pressure, which is the indicator if you have or you don't have high ocular pressure that can lead to glaucoma. So that's like the screening. We all should have obviously the vision, the refraction that we talk about. We should all have all the structures from cornea to lens to retina, optic nerve that ophthalmologists use, or optician, we all use the same device, and that's the slit lamp. They can use also for refraction the autorefractor like your cousin uses, but for the examination as such, the slit lamp is basically biomicroscope. And you put your chin on the device, and then basically it's really magnified, and we look with the beam, we shine to your eye. Sometimes it's really not comfortable, and we examine really from the front to the back of the eye. And why this matter? Because this it's really detailed evaluation of the cornea, of the iris, of the lens structures. Sometimes we find cataract and other structures that normally you can't see with naked eye, and also the retina and any lesions there. So the slit lamp examinations really like just the basics. That
really quick, is that like a slit? It's like a slit in the lab, so there's a light with a little, like, is it literally, because I have not seen one.
Yes. So it's basically a beam of light that you can make larger to the round or small, and with the light you are doing this and you're shining to the structures, and when you go in and out, it gives you the view of different structure of the eyeball. Sorry about that. My eyeball fall down. So basically the beam you shine in the cornea, and you can see if the pupil is small like this, you can see structure in anterior segment, obviously. And then with a special lens, I can even go and see inside in the eye. And therefore it's so important sometimes to dilate the pupil so I can see the whole retina. Obviously I will not see this and unless I push on it, because I indent it. But we usually watch for lesions that are in the periphery and also in the back, where there is optic nerve and macula. And so that's the slit lamp. That's really every ophthalmologist or optometrist would have this biomicroscope that we'll use for really, it's just cornerstone. Everybody should have this microscope and examine. So that's the basics. Then we can, if I do that personally, I have OCT every year. So OCT stands for optical coherence tomography. And what it does is basically it uses the infrared light, and it takes the cross sectional images. So it's like a scan, but it's really, think of it like ultrasound, but instead of sound is light. So it's really not dangerous, and it's really optimal for all range of patients. I use it for children if they come with headaches and they're really difficult to examine. On OCT, you can see every little detail, and I can see the optic nerve, because in case if something would be in the brain, I would be focusing on optic nerve, so it's not, any pathology. And it's really important to have one, like I would say every year or every second year, to really screen and detect early possibility of glaucoma, which will be on optic nerve, macular degeneration, or even diabetic retinopathy. So glaucoma is really, it's so important, because it's dangerous because people have no symptoms. So you don't know that you have glaucoma, that there is glaucoma. And people living their life, and then suddenly they just close one eye and see, well, my vision is not so great. They go to optician, and then the optician will discover suboptimal pressure, which can be over 21, so maybe 23. And if you have this pressure, or sometimes 30, if this for a very long time, it damages, it's pushing it on the optic nerve and basically creating damage, and people lose the nerve fiber layer. And OCT is so amazing that it can actually calculate how much of the nerve fiber layer you have. And now, why I'm saying it's great to go to every year and to the same person, because now we have the machine that learn we do the image, the machine will learn it, and next time when you come, I can see in great detail if there is progression or if it's stable. So I will really highly encourage everyone, just do this every year or every second year, and especially if someone has glaucoma in the family. It can be grandma or can be 2 generations back, but it's really important to screen for it. Now, of course, with metabolic health crisis everywhere in the world, we have rise of diabetes, and diabetic retinopathy is also on the rise. And I can tell you that people often, for example, so your sharp vision coming from here, right, from a macula. So you will not see much of visual disturbances if you have any changes from diabetic retinopathy here. Basically, diabetic retinopathy is a condition that we call from diabetes. So basically, diabetes in the eye. So if it's somewhere in periphery, you will not have any symptoms. And sometimes I will ask people, do you have diabetes? And they tell me no. But I see that they have already lesions in the eye. And sometimes when we don't do OCT, it's so small that you might miss it. But the OCT is amazing because it really tracks every little detail. And so that's really so much. We should use the technique to our advantage. And really, I would not encourage everyone for the safety, and really do it regularly, because it's really so helpful. So, and one more thing, you said if it's for first appointment on then regular, so then the ophthalmologist has to decide. So if everything is normal, if your optic nerve is normal, nice nerve fiber layer, and if macula is normal, then I would say you can come in 2 years. We can just check every year the pressure. If pressure is normal, you can do every 2 years. But if sometimes we need to do OCT every single visit if someone has already some condition. So if, for example, if I run glaucoma clinic, we do that every single year or sometimes every 6 months if I see that someone is progressing. So if we need to do, maybe this person needs surgery. So then it's really on the ophthalmologist to decide the urgency of the next appointment. But I would definitely, if you never had OCT done and you are more than 40 years old, please go to optician or ophthalmologist and have one done, because it can really help you for the future to just be safe. And we have this now in the world, we have these devices, so we should really have that. And if then if I go more specific to, so for example, if I see if I have a new patient, no symptoms whatsoever, but I see the disc looks a little bit suspicious of glaucoma, then I would consider through a visual field test. And before I will tell you about visual field test, it's important to talk a little bit about the eye pressure. So the eye pressure test, different people use different methodology. The pressure basically it measures intraocular pressure, so how, you know, inside in the eyeball, and we measuring it here. So either they do puff test, so that's non-contact. Basically, it's not touching the eye, but it's not very accurate. Sometimes we got referral from opticians. They refer patients with the high pressure, and then I measure it with Goldman tonometry, which is basically device. And I touch, we first numb the eye. We put drops that have fluorescein in it. So fluorescent dye. On the slit, people have the slit on the slit lamp. We put drops that are yellow, and they also have a numbing drops in them. And then with the blue light, we will, it's like a conus, and we will touch the eye. And this will give me a reading. I will then, with the button, will find out. So it's really special. So how I measure it is basically 2 full moons. It's too much detail, but it's just so fun. It's 2 full moons, and it should be like this. And if it's low pressure is like this, and if it's high pressure is like this, so it must be very correct. And this is really the best. This is the gold standard of measuring the pressure. So don't be satisfied with anything else. You want to have Goldman tonometry done, which is a contact, and you have to really have this if you want to have really correct reading. Then we also have eye care, which, for example, if someone is on a wheelchair, or I use it for children as well, which is like, you know, you don't have, this is just for screening purposes, then that we can use as well, but really the Goldman tonometry is most kind of accurate. And I see it sometimes that I told you that the when they measure it with air puff, the readings are very different if we do it with the Goldman. And also a little caveat to that. So if you imagine if you are pressing on a cornea, depending how your cornea is thick, then you will measure either, if it's very thick, you will measure artificially high pressure, and is very thin than normal. So normal is 550 micrometers. And if it's too thin, thinner than 550, you will go, you know, it will allow you and you will measure lower pressure artificially. So there's calculation that needs to be done, and that the ophthalmologist need to have this reading as well. So for glaucoma, always I like to have the OCT, intraocular pressure, corneal thickness, which is this one, the pachymetry we call it also, and then the visual field test. And the visual field test is really a test that it's kind of sometimes difficult to do, especially for the elderly individuals, because sometimes I have people who has glaucoma and they like 90 plus. And so for them, because you have to press the button, you have to see the light, sometimes it's very difficult because it requires really focus on the exam. So they know already, I always tell them, you have to be, you know, fresh, you have to focus, and you have to really be patient how you do this. And basically this test is really important. I would have it done as well at some point, especially if the OCT shows some kind of nuances that you need to follow. This would not be the first one that you have to be doing. I think OCT is really important, but it's really critical for detecting for early glaucoma or optic nerve damage, or even neurological diseases. Sometimes I have a person and they come to see us and we just suddenly find out that they have a stroke, because you will see it on a visual field test. You know, it's optional for 20 years old, because usually these people, we have known not much finding, But if you're 40 plus, once you definitely worth doing this. And this will kind of, these are the basic tests. Then of course people come with various conditions. For example, if people have dry eyes, then you do different exams. You can do test that it will screen for how your quality of your tears. There are various tests that ophthalmologists can use, and then is more specific. So we can also have other conditions. So for example, when we have age-related macular degeneration patient, and they come like everything is suddenly wavy, then we for sure do OCT. But the OCT usually targeting only the optic nerve or the macula. So we can target it macula. And again, it's just so beautiful how, you know, when I started doing ophthalmology, we did not have OCT. In 2003, we did not have OCT, and we, as a junior doctor, you have to, with a lens, really look carefully. I'm thinking, is it like elevated or it's flat? That's how is. If it's elevated, means that there is condition like AMD, and it was really difficult to distinguish. When you are junior doctor, of course, when you look more, then you know how what you're looking for. But when OCT came into the hospital and we started using it, it was like, it was a revolution, because suddenly we could see in much more detail, and we could actually follow up, as I told you, you know, with the glaucoma, with AMD, see how, for example, the injection, if it's working or not, because we see on OCT if it's the inflammation and the swelling going down, or if it's still up. It's such a nuances. So it's definitely not, it's really worth investment. I know in US, you obviously, it's insurance and all the different things you have to think of. Here in the UK, we don't need to think about this, but OCT is definitely something that I would always pay extra for that. And so yeah, so I hope I answered the question. Basically, you have to, for the screening, you can do more tests for the beginning, and then depending on what doesn't look that ideal, you can follow that up. So for example, as I come back to the glaucoma, if you have first OCT and looks normal, then you can like relax and you can have it maybe every 2 years. But if it's something like looks suspicious and there is little thinning of the nerve fiber layer, then I would do every year, if that makes sense.
Totally makes sense. That was a lot of information. And
Sorry.
by the way, some people commenting on my glasses. I mean, it's like late night here, and we're trying to both sleep after this. So I'm wearing my blue blockers, but yeah, I don't need prescription glasses. But that's beside the point. So I want to, like, there's a couple of things you said. So basically the OCT is like this new tool that's super safe to use, which gives you very accurate information, also how you track things, right? So it's a way to see things going forward. I always had the puff test for intraocular pressure, so I'm super cool because we're going to test my vision tomorrow, and I cannot wait to experience this other one. And the corneal thickness, I think, is the thing that no eye doctor has ever told me anything about my corneal thickness. But you're right, it makes sense, right? When if the cornea is very thick, the pressure can show up as like I always think of like a hose of like water. If it's a really thick, like sturdy, the pressure can show up as really high when it's really normal. But when the cornea is super thin, like LASIK, right? It's thin. All of a sudden you're like, oh, the pressure is normal, when really it's not normal. So you have to use your formula of the thickness of the cornea, the pressure, and so that I've never heard an eye doctor say that. I think that's, and maybe they're doing it, but they just don't tell you.
I think they're doing it. And you mentioned something that I actually want to fill a little bit. Also, you mentioned LASIK. So yes, for those who had LASIK or any refractive surgery, you have to measure the thickness, because it's like 100 less microns less, and this make really difference when you're calculating the pressure. And also people with myopia, especially with high myopia, also have tendency to have thinner corneas. Not all of them, but because the eye is longer, that sometimes as well the cornea it's thinner. And also one more thing, for astigmatism or for keratoconus, we can do the topography, which is like a perfect picture of the surface of the cornea that gives us the shape. But yeah, definitely the corneal thickness is something I think doctors do, just that if they don't, remind them, because they will do it. It's just as well, this is a gold standard. Sometimes, they just maybe, I don't know, I don't want to comment it, forget or something, but just keep eye on it yourself. So you want to know all these readings. What is your pressure? Know it, and all these other results from the test. So really important to know, and be really know what is in your eye. So
Okay, so quick question. So one thing that I hear different things about, and a lot of people were wondering, because I get that question a lot, and I'm like, I'm not the expert in this. What about the dilation? The last time my pupils were dilated, I was a child, and I remember being totally traumatized because it was so bright, and I had to wear the the little paper, whatever, sunglasses, because I didn't wear sunglasses as a kid. So some eye doctors say you always have, like, the only way to actually check your eyes is to do a dilation. My second cousin, who I've been seeing, never did a dilated pupil exam. So what's the deal with the pupil dilation? And is it safe? Because it's a very mild atropine solution, I think. So can you tell us a little bit about, would you always do that? Would you never do that? When would you do it? And tell us about that.
yes, thank you. So yeah, that's a great question, actually. And I actually had on Tuesday, yesterday, I had a gentleman that was the first appointment. I had to dilate him because as always I do the thorough exam, which dilation is required, and that's how we do it. And it was so impossible to examine because he really didn't like the light. So I think what is more than dilation is the light that comes to the eye. Is like, it's a huge amount because suddenly your pupils are large. So it's very safe. We don't use atropine. We use some drops that are milder. Atropicamide is one, but you don't need to remember. Nobody uses atropine, I think, these days for adults. And it's good to have eyes dilated because this is how you can see the whole retina. If you look through the pupil that small, you will see only area that much in the back. But if you make the pupil wide and people look up, people look left, right, you can see really a wide range of the retina, and you can uncover a lot of pathologies if there is some. And again, people, they don't have symptoms, and then they go to the proper thorough exam, and then there is something. So I'm not saying that we need to do it every single time, but we always do it on the first exam. You do all these tests plus dilation, and this is how you find a person that has diabetes and was never diagnosed. So you uncover conditions that people are not aware of. Not always. This is like the kind of the bad scenario, but the good scenario is that you have the dilation, we don't find anything, and we will rule out, so the eyes are fine. So I think, once obviously when you're always changing eye doctors, they will always would like to do that at the first exam too. So if you're staying with one, you will not be required to do it every single appointment unless you are diabetic, unless you have they're watching for the cataract, and or you are having AMD or any medical retinal condition. Then we have to dilate every time. Diabetic patients always have to be dilated to view the whole retina. If you have glaucoma, or if you're just going for checkup, you have no conditions in the eye, you don't need to be dilated. And yes, with dilation, we can really see also the lens fully, because without dilation, you really can't assess the cataract, for example, or the lens, if it's gray or not, and other structures in the eye. So yeah, it's important. And I really, what I think people don't like is the amount of light that's coming to the eye. So what I do, I always put very short beam and very low light, so people can really tolerate it better. And you can talk to the doctor. I said, I'm so sorry, can you reduce the light? They will do it. But you just have to, you know, say and have a conversation about it. Like, I'm so sorry. That was so difficult for me. It's coming too much light in my eyes. Can we do it? Can we reduce the light? So it can be more kind of comfortable for me. And, you know, it's possible. We can
That is a
examine
great
also with
point,
low
though.
light.
I wouldn't have known that you can. So if it's too bright, because obviously nature intended our pupils to be tiny with bright lights, and when we enlarge them, so it's really important. We're going to do that tomorrow with me. I'm going to, and I'm going to like, hey, less light. So you can basically ask to have less. That's really good. So you talked about the lens. So we talked a lot about the retina, finding like, glaucoma, the optic disc, the optic nerve. We talked about the macula, the retina, the vessels, the, diabetic retinopathies. So what about the lens? The cataract is always the number one question I get all the time is cataracts. So in order to see the full lens, we have to dilate the pupil. So, we don't really know what's going on otherwise, right? That's what you're saying. So
Yes.
I always hear people talk about the stages of cataract. Oh, I have an early stage, or I have a stage 3, or can you explain a little bit what the different stages mean? And also, at what point do you recommend a cataract surgery, or at what, like, can you walk us through that process a little bit? Is it like stage 3, stage 4? Like how does this all work?
Okay. So if you imagine the vision is so the light coming through here, so it's the cornea, right? Is anterior chamber, then is lens, then is vitreous, and then is macula. Then it's called the brain, and then goes back, and then how we see. So there are mediums. So it's cornea that can be hazy that we can't see. It can be something in anterior chamber inside here that will cause that we will not see clearly. It will be hazy. It can be the lens that can be hazy, or it can be something in a vitreous that can be hazy. We would not be able to see, or it can be something in the retina. So we always have to think comprehensively, like what is it? Why people don't see? Like, is it cornea? No. Is it lens? Yes. Is it in the maybe floaters or some inflammation, or what is it? So that's we have to distinguish in the beginning every single time to really diagnose what is it, why people don't see. If there is only cataract, otherwise because sometimes people have Fuchs dystrophy and cataract, and you have to ask yourself, so does this person doesn't see well because of the cornea that is hazy, or because of the lens that is hazy? And then you have to be really good. You have to have a good judgment and to assess, like, okay, what if we do the cataract surgery, will the vision improve to the degree that patient will be happy, or are we doing it something that would not benefit the patient? Because I think always with the cataract surgery is always a risk and benefits. Every surgery, even if cataract surgery is so safe, it's always a risk. Something can go wrong. And benefits, we're taking the risk because vision improvement will happen. And so we always have to assess that it's cataract is only reason why this person can't see well. So make sure that it's really, that's the case, that you want to kind of do the first step. And now, if it's only cataracts, the other media is clear, you don't have age-related macular degeneration, and the prognosis is good. So we will take the risk to have really benefit, because if you have cloudy lens and you put instead clear one, the vision really will improve. So normally, if the vision drop to 20/40, because that's usually in many countries legal driving, then that's corresponding how the lens is really cloudy. So we have, I think should explain also that lens we have few types of cataract. So we have nuclear sclerotic. That means that it is in the middle, the nucleus, as we call it, in the middle, which goes yellow. and this will cause glare at night, or you will need stronger glasses. So that's why sometimes the optician change the glasses before they list you for cataract, because we can still manage with glasses. So that's the early stages, but we can still manage with prescription. Then there's another type, which is cortical, which is like the spoke-like opacities, causing the light scatter and halos, and that's more in the periphery. And then the one that people who has other conditions, they can develop, the lens can be quite clear, but in the middle they will have like very dense opacity they would not be able to see, and that we call posterior subcapsular. And you don't need to remember, but it's very typical, it's very specific type of cataract. It's just in the middle, and it can be maybe really like young person, like maybe 45, 50, and they will develop this type of cataract that is just in the middle. But because this is where you actually see through, it's important to realize that yes, this person is not old, but he will benefit from the cataract surgery. So I think we always guided, yes, how the lens look, but we are guided by the patient. If the patient really can't see well, and it's really it's already below this 20/40, we definitely list for cataract, because we know that we take the risk because of the vision improvement will be really good. Because at the end of the day, it's naturally we all have some clouding. Unless you are like, I have a patient was 2 weeks ago. He's a gardener, and his lens, he was like 80 years old, and his lens was clear. And I said, can I ask you what you do? I'm a gardener. You would think, well, he's in the sun all day. Well, in England, he's in the sun outdoor all day. You would suspect that he has some cataract, but he didn't. So I think the light exposure in his, in here in this climate is really beneficial. So yes, we worried about UV damage, but actually, we don't have enough the good light in the eyes anyway, so we don't need to be so worried. And so yes, so I think it's always combination of how, if patient would take the risk. That's the first one, because there's only few occasions when we need to do the cataract surgery, so it comes from the doctor. That's when the eye is too small, when especially people who use plus lenses, they have hyperopic eyes, so the eye is too small, and this space here, it's really shallow, and if the cataract inside kind of grows, it's pushed the iris in the front, so this will be really a small space, and this can create really high pressure in the eye. So this is only one of the conditions when we really say, you know what, you don't have yet cataract, that we normally will operate, but to save your vision and prevent you from glaucoma attack, we have to remove the lens. But generally, normally, we really, I'm always guided by the patient when they decide that, okay, I can't read, I can't drive, everything is hazy, I want to have it done. And there's always combination, how the lens look, how dense, how yellow the lens is, and the visual acuity. Because if the visual acuity is still good, and I would never go for it, because people will not, they won't be happy. You always have to see the improvement, otherwise it's too much risk. So for example, just to conclude it, just simple example, if someone comes and the vision is 6/9, so a little bit not 100%, 20, you have 20/20. So if it's a little bit worse than 20/20, and I see cataract, I can say, oh, there is a little bit of cataract, but don't worry, it's progressed very slowly, and you might never need cataract surgery. But this is like wrinkles on the skin. We always have some if you are 80 or even 70. So in this person, I would never, if the vision is good and I see already cataract, even if it's for operation already, how the lens look, I will be always guided by how the patient feels and what is the vision like. So if the people have good vision, I would not go for it. And someone's asking what are actual measurements for cataracts. That's the vision. And also how it looks. We can do also biometry. but then we do that only when we are planning cataract surgery. So you would not have this test normally. This is only when we're preparing for surgery. But the diagnosis of cataract is pretty straightforward. It's not difficult at all. So yeah, I think the visual acuity is always the one that you want to check and see if you really want to go for the operation, because sometimes people are happy to not have anything and they're happy with the vision as it is. And some people are so eager, yeah, I want to have it done, I want to have this one and the second. So we're all different. So I think it's very individual, but it's really so important to talk with the doctor and understand everything. Also the side effects. Also, if you want, because then you choose a lens, and there are different type of lens. It is for another discussion.
Yeah.
But then you have to really talk through it. What are the expectations and what will be the result? Because then people are sometimes very disappointed. Often not. Often people are really very happy after cataract surgery because they see again. But yeah, it's always surgery. So yeah, it needs to be talked through and really make it clear what the results can be potentially.
I really appreciate your candid approach here, because I know you told me earlier how you love doing surgeries. It's like something, but I think it's really important to point out that, it's like, except that case where you said the eye is too small and literally like a glaucoma attack leads to blindness, and you want to, like, from an anatomical position, like saying, hey, this is really dangerous not to do the surgery because the lens is growing and putting all this pressure on the eye. But otherwise, it's like you said, lifestyle impact, like how does it impact your lifestyle, and also the type of cataract. So really understanding that. And I love that you said the gardener, because usually we hear like the sunlight is bad. And as you know, I'm a big fan of sunlight, but I also know there is also too much sunlight. Most of us do not get too much sunlight, but some people might get, depending on where you live and what you do. But yeah, I think overall it's really important. That's
So
really encouraging to hear.
I just before I forget. So yeah, that's the light. Yeah, I know we are on the same boat. I as well, like, let's be outdoor as much as we can. And really, this what we're doing now, Claudia, is not good for
No,
us.
this
But
is,
anyway,
we are messing with our circadian. That's why I'm wearing the blue blocking glasses.
yeah.
But we're
But
almost.
what I want to just share with you, like, I was in India doing cataract surgery in January, and the patients with cataracts that was really dense were much younger than here in Europe, and in different. So yes, UV light, it is really causing the damage. But if you are doing things consciously and really using only UV glasses when it's really needed, then I think the light is more beneficial than not. Yeah.
That's really great to know. So let's see, what other questions? There was a question earlier that I thought was interesting. Is high blood pressure connected to a high intraocular pressure?
So yeah, so if you ask your doctor, probably they will say no, it's not.
I know,
But
that's what I heard from other people. They said, I had
because
a client that actually called me, she went totally blind within a year. And she had high blood pressure, and she said her eye doctors would say, no, that has nothing to do with that. To me, it makes logic sense somehow. But
so
okay.
it's not direct. It doesn't mean that if you have high blood pressure, you will have high
Okay.
intraocular pressure. It doesn't work like this. But there are ways now. It's actually one scientist in Mount Sinai and in New York. He's doing some research, and I think we soon will know as well the mechanism, how it works. But definitely, there are some connections. So yeah, you don't want to have high blood pressure anyway, because it's cause all these other morbidity and mortality. So and I would, yeah, definitely same for low pressure. All my normal TENS glaucoma patients have low blood pressure, and that's, again, is not enough blood flow to the tissue. So that's a different problem. So definitely, yeah, everything is connected to everything. Sometimes we don't know how, but I think eventually we will find out. And I don't want to be late. So let's think everything is connected with everything. And even we don't have all these answers, but I would always think out of the box for sure.
So there's a few questions on YouTube. I know we've been going for a while, but I know this was a hot topic too. So so I think glaucoma, right? I know you're very passionate about this because it's called the silent vision killer, because again, you lose your peripheral vision, not your sharp vision, which the sharp vision with cataract, if it's like that central cataract you were talking about, or macular degeneration where we see things wavy, we see that, right? We notice that, but we don't really notice when we lose part of our peripheral field. So somebody's asking, is glaucoma genetic? Or is that something that you can also develop? Or is it, can you quickly, I know this is kind of,
Yes.
but without
No,
going
that's
into,
fine. No, it's both. So we don't have like one gene that causes the disease. Some of these hereditary condition that's just one gene. Like for example, polymorphous corneal dystrophy is just one gene. So if you have that gene, you have this condition. With glaucoma, it doesn't work like this, but it runs in families because the risk is really higher if your mom or dad had glaucoma or even grandma. So I always tell patients like tell your siblings, check your children, like the whole family should be checked because it can be both. And of course lifestyle it's also as usual as you will think has influence on that, because we know, for example, diabetic patients, they have higher risk for developing glaucoma as well because of the toxicity of the high glucose, and developing glaucoma. Also, diabetes is basically makes everything worse. Also, the cataract. We know that diabetic patients has much earlier cataract than patients who don't have diabetes. Or yeah, so definitely, I would be very thorough and check your eyes. You need to do that pressure with the applanation tonometry, with the Goldman tonometry, with the blue light. If they're doing blue light, you have that what you need to have, and then the OCT and the corneal thickness, and then eventually also the visual field test. It's really important, these things, to rule out if there is glaucoma or not. I always tell patients that it's not like pregnancy, glaucoma diagnostics. If you're pregnant, is yes or no. It's 0 or 1. With glaucoma, we sometimes say, I'm not sure. We will watch it in the way that if the pressure will go up, then we have to, do some therapy and start maybe drops or do laser. But it's really important that we know what's going on. And so I'm absolutely against, for example, diabetic retinopathy to say, well, let's see, you don't have diabetic retinopathy yet, let's watch it. So I'm against this approach because I don't want to just watch things. I want to optimize things. So things what you can do, we always, if you want to look which your people like, your listeners want to see what else you can do, you always have to think of everything. How you are exposed to light will help you understand, and will definitely have effects of if your glaucoma will develop or not. The way how your blood sugar regulation will be controlled, that will be there. If so, potentially, if you develop diabetes, your glaucoma risk goes high. And other conditions, if how much you're doing sport, how you exercise, the health of your mitochondria, I don't want to go too much into the details, but all these aspects that you talk about, they all matters. It doesn't mean that we will, if we do all that, we will never develop glaucoma. But we know from twin studies, if you have two people with identical genetic information, one will develop glaucoma, I will go blind. If they don't take care of themselves, they don't go for the visits, they don't do healthy lifestyle, and other person will just never go blind. Maybe will need some drops, maybe will need a surgery, whatever is needed, but never lose the sight. So it's just so important to know what's going on, and have a I don't want to use the control, but it is a little bit of control, and just be compassionate to yourself. If that's something in your family, so you better check it, because it's better to check it before it's too late, because this is irreversible condition. That's what is so dangerous about without symptoms.
So we should definitely do a whole episode on cataracts, but so a couple of questions I thought were helpful. Are there a good, what is a healthy, we have blood pressure, we like 120 over 80, right? But what is like a good range for intraocular pressure? Like what is the highest it should be, or the lowest?
So it should be not more than 21.
Okay.
And you have to account as well the corneal thickness. But if you do the calculation which your doctor will do, it should not be more than 21. And so normally people have between 14 15 when they're younger, and then it will, because the eye becomes more stiffer. You know how especially women after in perimenopause and menopause go stiff, everything hurts, they have the shoulder, and so the same is happening in the eye, and the eye goes stiff. So the outflow from the eye is not like was before, because the tissue basically is changing, it's more rigid, and the glycation, the from the blood, again back to the sugar, the blood sugar, as again it can get worse as well, the outflow, because of this like little it's a trabecular, I don't want to give you too much names, but the outflow here, basically the outflow here, not out from the eye, but in the chamber it goes out. And when it's narrow, or when we have in a diabetic patients, it's really compromised, that can really increase the intraocular pressure. So 21 is the highest that I would like to have. Sometimes we have patients when they have acute glaucoma attack and they come with 60. They sometimes can go blind, and that's something that's emergency. Usually what happens, there's a few more reasons, but I tell you just one, that if you have really red eye and you can't see suddenly, your pupil is a bit large, and you have a headache that you just can't be, immediately go to the doctor, because to ophthalmologist, because they will need to do laser here, little hole, to make more space to prevent you from permanent damage. We have that quite often. A few times a month there is a patient that comes like 60 pressure with really horrible pain that they just can't be, so that's something, but that's, you have a symptom you have to deal with. Another emergency that I would everyone see ophthalmologist or optician is when you have flashing lights, and then you have curtain coming from the either side. That's another emergency, and that's the retinal detachment. And usually people come because it's really visible, so we can save the eye. But with the chronic conditions, the glaucoma is the one that really leading the way, that it's just so missed. And I hope this will help really to your listeners to really go find ophthalmologist or optician and check for this, because it's just so important, especially if someone in your family had this condition.
Well, thank you so much. So we can go for hours, but it's like we can do another episode at some point. So I think this was really, really helpful. So emergency level stuff is the acute glaucoma attack, red eyes, headaches, and just like what else is like, is there any other symptoms like intense headaches and red eyes or?
Yes, so really red eye, the vision is very blurry, because the cornea will get really hazy, because it will be like swollen, and the pupils sometimes go bigger and irregular, and people can't miss it. It's really, you just can't exist, because it's so unbearable pain. So don't wait. I just give you a tip: don't go to urgent care or anywhere to A&E. Just go find your eye doctor, because you have to use the slit lamp to examine, if that makes sense. That's really important, because I see sometimes people tell me the story, oh, I went in the morning to GP, and GP sent us here, and they came at 4 o'clock in the afternoon. So it's like such a waste of time. From the morning we could already but that's a system that we need to follow. But if you can avoid that and go straight to ophthalmologist, or go privately or something. Basically, this I would go. Hopefully, we will not have ever this issue.
And the other thing is that, so just really to be clear, so there's also the half moon kind of like light sometimes, which is more the vitreous detachment, but you were talking about emergency stuff more.
That's
There's like
retinal.
curtains, there's like things like I had a person once describe it to me like they lost like almost like, yeah, as if there was a blackout curtain happening and like
Yeah.
parts of the visual field were literally blocked and the flashing lights. So that's emergency level.
Yes. Yes,
Okay.
because that's the retina that basically it can be a little hole, and then the water goes underneath and that starts detaching and inside in the eye, and then you will see it, or because it will be kind of black. Exactly. It can be either side. It can be like a curtain or just patch, and it will be slowly, gradually going bigger. But again, hopefully we'll never have this problem.
I know, but this is like really,
Yes.
we wanted you to guys to know, like, because sometimes I'm like, oh, I want to see an eye doctor. So those are the two, like, don't wait, don't call, like, just go to the ophthalmologist
Yes.
and
And
get that so that the repair, whatever is still possible, is possible in that small time frame that's left probably. So we will do another whole episode on cataracts because we have so many questions on that. But
oh,
where
really?
can people find you? What's the best way? You practice in the UK. You did cataract surgeries in India and in the UK. But where can people find you that are not local to the London area?
So I have an Instagram account, dr.radka.toms, and you can find me there, or on I'm on I have email radka@mysugarstop.com, and I also do work in private clinics, Matrix Eye Clinics, or U Health. So these
Didn't you
are
have like
clinics.
didn't you have some free
I
you,
have, yes.
I
You have,
have
I
to I
think
don't
the
have
link. Katrina has the link, so you can
okay.
join that. It's a food as medicine workshop for gut eye axis. That's my passion. I believe that ophthalmology should be more integrative and more kind of thinking of the body, because we think too much too far, and we don't think often as ophthalmologists of the body. We just see the eye. So it's like we should really look beyond the eye and connect the dots. And now with the new science of the gut microbiome, we can really help patients to stabilize or optimize the glaucoma and age-related macular degeneration and dry eyes and diabetic retinopathy and uveitis. Those are the conditions that are known to be influenced by the gut microbiome. So that's something that it's new science, and I'm so excited so we can
Posted
help
in the
people
chat.
better.
I posted it in YouTube as well. It's in the show notes,
Okay.
but it says checkout at the end, but it's free. You're offering this kindly totally for free. So, well, thank you so much. We're gonna have a little bit of a small after Q&A in My Clear Vision Club. So thank you, YouTube. Make sure you subscribe, follow Dr. Radka, because she is I think you call it nutritional ophthalmology, but you're really interested in educating other people, other eye doctors, especially on the microbiome and how important that is for our eye health and to prevent most of all these horrible things. And then also, any final words? I would say go see your ophthalmologist, get your eyes screened. Just like, I always say you wouldn't say I don't have time to brush my teeth or get my teeth checked. Don't wait till you have a toothache, aka like vision problem, but get that screened and make sure that your eyes are healthy, right? So that you don't end up with any of those diseases that are often
Mhm.
preventable. Thank you, thank you. Any
Thank
final
you.
word you want to say? Any last?
I'm just enjoying always conversation with you, Claudia. I really love your work. As you can see, I do wear glasses because of my job. Maybe one day when I retire, I will drop that. But I just love your work, and I wish every ophthalmologist is open-minded and explore this what you teach, because I think you help people in a big way. So thank you, and thank you for. I really enjoy always share conversation with you. Thank you.
Well, thank you for being here. And even though it's late, and I know you shared with me that your working condition as an ophthalmologist are not helping with your vision, right? Because you sit in that dark room. So it's when you didn't practice for a while, you told me that your vision, you didn't even need the glasses anymore. So
No.
we know, and how important lifestyle is. And sometimes if you have a job like yours, where it's just not optimal, but you do the best. So thank you for being here and educating us, and thank you, YouTube, and we see you next week for Clear